Hey everyone, and welcome back to Study Nurse IQ. I'm Jeannie. Today, we're going to talk about beta blockers, a class of medications you absolutely must master for your exams and clinical practice. Make sure you watch until the end because we'll practice NCLEX style questions together to really test your knowledge. Let's get started. As we navigate this pharmacology series, we always rely on the nurse mnemonic to cover the essential concepts. We'll start with N for name and mechanism. First, let's identify these medications. All beta blockers in their generic name end with LOL. Think of drugs like metoprolol, atenolol, and propranolol. If you see that LOL suffix, you know you're dealing with a beta blocker. But what does it block? The drug family name tells us everything. Beta blockers block the beta receptors in the body. To understand why this matters, you have to know what typically activates those receptors. The chemicals that bind here are called catecholamines, specifically norepinephrine and epinephrine. These are the hormones that control your sympathetic nervous system, SNS, better known as the fight or flight system. If we block the receptor sites, norepinephrine and epinephrine can't bind, and that means we won't elicit a strong sympathetic nervous system response. To really grasp the power of a beta blocker, let's quickly review what the sympathetic nervous system normally does. The sympathetic nervous system increases your heart rate and your blood pressure, which boosts cardiac output. It increases the strength of the heart's contractions by exciting the cardiac cells or myocytes. It increases the oxygen consumption by the heart muscle, myocardium, because the heart is working so much harder. It causes bronchodilation, widening of the airways, in the lungs to get more airflow to meet the heart's increased oxygen demand. It increases blood glucose via a process in the liver called glycogenolysis, giving the body more energy for the emergency. In a healthy person, this saves your life. But in a patient with heart issues, this sympathetic response is actually harmful. It makes a sick heart work too hard. That is why we use beta blockers, to decrease the workload on the heart and bring the blood pressure down. Beta receptor types, where the action happens. Beta blockers can affect different receptor types throughout the body: beta 1, beta 2, and beta 3. For this lecture, we are focusing on the first two. Beta 1 receptors, B1. Think of one heart. B1 receptors are mainly found in your heart. They are also found in the kidneys in cells called juxtaglomerular cells. When stimulated, these kidney cells release renin, which is the start of the RAS cascade that eventually increases blood pressure. Beta 2 receptors, B2. Think of two lungs. B2 receptors are mainly found in the lungs, specifically in the bronchioles. They are also located in the GI system, the liver, the vascular smooth muscle, and the ciliary body of the eye, relevant for glaucoma treatment. Selective versus non-selective beta blockers. Understanding these receptor locations helps us differentiate the two types of beta blockers. Selective, cardioselective. These are very selective. They target only the beta 1 receptors, which are mainly in the heart. Because they primarily produce cardiac effects, they are generally safer for patients with lung conditions. Examples include atenolol and metoprolol. Non-selective. These are not very selective. They target both beta 1 and beta 2 receptors. They have strong cardiac effects, but they also affect other systems like the lungs. Examples include propranolol and timolol. The dual mechanism of action. Both types share cardiac effects by blocking B1 receptors. Slowing the heart rate. They affect the cardiac nodal tissue, making them excellent for treating fast, abnormal rhythms, tachycardias. We call this a negative chronotropic effect. Weakening contractions. They decrease the contraction strength of the cardiac cells. We call this a negative inotropic effect. This is beneficial because it decreases the oxygen demand of the heart, but we must watch for signs of heart failure if contractions become too weak. Lowering blood pressure, kidney block. By blocking B1 receptors in the kidneys, they inhibit the release of renin. This prevents the RAS system from generating vasoconstrictors like angiotensin II, which significantly helps lower blood pressure and volume. The non-selective types have additional effects because they block B2 receptors. Bronchoconstriction, blocking B2 receptors in the lungs, can cause the airways to constrict. This is why non-selective beta blockers are contraindicated in patients with asthma or COPD. Glaucoma treatment. In the eye, B2 blockade can decrease intraocular pressure by reducing the production of aqueous humor, making them useful for glaucoma. Blood sugar issues. These drugs can cause hypo or hyperglycemia in diabetic patients. Peripheral vasoconstriction. This effect can lead to side effects like cold hands and feet or even erectile dysfunction, and they should be used with caution in patients with peripheral vascular disease. Now let's move into the U in our nurse mnemonic, which stands for use. Beta blockers are incredibly versatile in treating cardiovascular issues like high blood pressure, hypertension, stable angina, chest pain by decreasing the heart's oxygen demand, dysrhythmias, fast and abnormal heart rhythms, compensated heart failure in stable patients to prevent remodeling, glaucoma, migraines, tremors, and anxiety. Now that we've covered the main uses of beta blockers, let's shift into what really matters for us as nurses: understanding our responsibilities, monitoring for side effects, and teaching patients what they need to know. We'll use the block mnemonic to make this simple and memorable. B. Bradycardia. Monitor the heart rate and EKG. The heart rate should not be too slow, typically below 60 beats per min, but check parameters. Watch for signs of a second or third degree heart block. L. Lowers blood pressure and lung issues. Monitor blood pressure. Teach the patient to monitor their blood pressure daily at home. The non-selective types are an absolute contraindication for patients with asthma or COPD due to the risk of bronchoconstriction. O. Orthostatic hypotension and overdose. Teach the patient about orthostatic hypotension. They must rise slowly from lying or sitting down to prevent dizziness and falls. Also, know the signs of overdose: severe bradycardia, severe hypotension, and mental status changes. C. Circulation impaired and contractions weakened. The non-selective drugs can cause peripheral vasoconstriction, leading to circulation issues like cold hands and feet or erectile dysfunction. Also, monitor for signs that the heart's contractions are too weak, which could exacerbate heart failure. Example: crackles in the lungs, weight gain of more than 2 pounds in one day, swelling. K. No sugar and tapering. Teach the diabetic patient that beta blockers can mask the tachycardia that normally signals hypoglycemia, so they must monitor their blood glucose very closely. Crucially, teach the patient to never stop the medication abruptly. They must be tapered off, usually over 2 weeks, to prevent dangerous rebound hypertension or chest pain. All right, we've gone over the essentials. Now let's test your understanding with a few NCLEX-style practice questions. Question 1. The nurse is teaching a patient about a new prescription for a non-selective beta blocker. Which health history finding noted in the chart would require the nurse to hold the medication and contact the physician? A. History of compensated heart failure. History of stage 2 hypertension. C. History of persistent exercise-induced asthma. Current complaint of chronic anxiety. The correct answer is C. History of persistent exercise-induced asthma. Rationale: non-selective beta blockers, like propranolol, block beta-2 receptors in the lungs, which can cause bronchoconstriction and trigger a severe asthma attack. Asthma is a near-absolute contraindication for non-selective beta blockers. Question 2. A diabetic patient receiving metoprolol reports waking up feeling dizzy and weak. The nurse notes a current heart rate of 52 beats per minute. Which statement by the patient indicates that further teaching is needed? A. I need to check my blood sugar more often since this medicine can hide my low sugar symptoms. B. I should try to get up from the bed faster in the morning to keep my blood flowing. C. I will call the doctor if my heart rate stays below 60. D. I know this medicine is slowing down my heart to help my blood pressure. The correct answer is B. I should try to get up from the bed faster in the morning to keep my blood flowing. Rationale: this statement indicates a need for further teaching. Beta blockers commonly cause orthostatic hypotension. The patient must be taught to change positions slowly and deliberately to prevent dizziness and falls, not faster. Question 3. A patient is being discharged with a new prescription for propranolol. The nurse's teaching plan must include the risk of rebound hypertension. The nurse explains that this is caused by A. The sudden drop in angiotensin II levels when the medication is stopped. B. Increased fluid volume due to unchecked aldosterone production. C. The heart muscles suddenly demanding more oxygen than the blood vessels can supply. D. Rapid activation of the sympathetic nervous system when the blocking effect is removed. The correct answer is D. Rapid activation of the sympathetic nervous system when the blocking effect is removed. Rationale: rebound hypertension and myocardial ischemia occur when a beta blocker is stopped abruptly. This sudden removal of the blockade allows the sympathetic nervous system, fight or flight, to surge back into action immediately, causing a dangerous spike in heart rate and blood pressure, hypertension, and increasing the heart's oxygen demand, ischemia. And there you have it, a complete breakdown of beta blockers. You now know the name, the mechanism, the side effects, and exactly what to look for on your exams. Remember to like this video, subscribe to our YouTube channel at Study Nurse IQ for more teaching content. I'll see you in the next video.